All right, let's go ahead and get started as folks are coming in. Welcome everyone to this event. My name is Emily Moore and I will be moderating today's webinar event, an introduction to open dialogue, overview, implementation, and next steps. I am joined by the director of the Southeast Mental Health Technology Transfer Center, Dr. Benjamin Dress, who will be assisting me in introducing today's speakers. But before we get started, I want to give everyone just a little more info about our center and what we do. So please just note that our center is supported by a grant by the Substance Abuse and Mental Health Services Administration, or SAMHSA. And also please note that our center, as well as the larger MHTTC network, uses affirming, respectful, and recovery-oriented language in all of our activities, and I encourage everyone who will be commenting in the chat today to keep that in mind as well. You're welcome to visit our website to learn more about our upcoming events and products. And before I turn it over to Dr. Dress so that he can introduce today's speakers, I also want to go over a few important notes for today's event. Please note that this event is being recorded and will be posted on our website for on-demand viewing, typically in about 72 hours. We also have a chat feature, and we encourage you to share your thoughts using the chat feature at the bottom of your screen. Please remember to select chat with all attendees to share your comments with everyone in attendance. Please note that we will also devote time at the end for the presenter to answer your questions. Please submit your questions for our presenters using the Q&A feature at the bottom of your screen. And finally, for any attendees that are interested, you can download a certificate of attendance for your records upon completion of our evaluation surveys. All right, and I'm going to go ahead and turn it over to Dr. Dress so that he can present today's speakers.
Thanks so much, Emily. So I'm really looking forward to today's presentation, but I will start with introducing the two presenters. The first, Robert Cotes, is an associate professor at Emory University School of Medicine in the Department of Psychiatry and Behavioral Sciences. He's director of the Clinical and Research Program for Psychosis at Grady Health System, which comprises two clinical programs, PSTAR, which provides evidence-based recovery-oriented care for individuals with persistent symptoms of psychosis, specializing in the use of clozapine, and Project Arrow, a coordinated specialty care team for people experiencing early psychosis. Rob serves as physician expert for SMI Advisor, which is funded by SAMHSA and administered by the American Psychiatric Association. SMI Advisor is a wonderful program. It provides evidence-based resources to clinicians, individuals with serious mental illness, and their families. And within SMI Advisor, Rob co-directs the Clozapine Center of Excellence and long-term acting injectable Center of Excellence. Our other presenter will be Justin Palanchi. He is an assistant professor in the Department of Psychiatry and Behavioral Sciences at the Emory University School of Medicine. He serves as medical director for the Assertive Community Treatment Program at Grady Memorial Hospital. His interests include recovery-oriented care for persons experiencing serious mental illness, racial disparities in the assessment and treatment of psychosis, and the relationship between trauma and psychosis. Dr. Palanchi is certified as a Dialogic practitioner and trainer through the Institute of Dialogic Practice. So now I will turn it over to Rob and Justin. Again, just really excited about this presentation today.
Thank you, Dr. Dross, and thank you all for welcome this afternoon, and thank you all for being here. Look forward to spending a little bit of time together today. I'm going to pull my slides up. All right. So Rob and I are here to talk about a little bit about the open dialogue approach to psychosis. I don't know, Rob, if you'd like to say anything at the start.
Well, I want to just thank Dr. Druss and everyone for being here and for giving us the opportunity to give this talk. I think what we hope is that, if you are familiar with open dialogue, we want to give you a little bit of a sense of some of the work we've been doing at Grady. If you're not familiar with open dialogue, we'd love to give you a sense of what open dialogue is and how it's been able to shape and transform the way that we look at things, and maybe our services to some extent. So the talk is basically divided into two parts. So first, Dr. Polanski is going to give us an overview about what open dialogue is, and then I'm going to talk a little bit about some of the work at Grady, and then we're probably going to be going back and forth kind of throughout, and hopefully we'll have some time to give some reflections, maybe even as we're in the presentation.
All right, and with that, so here are our disclosures. And Rob touched on this, but we're going to just talk a little bit about the background of open dialogue, how it was developed, talk about the principles and elements to the approach, and then talk about implementation at Grady and maybe some other projects happening worldwide. Okay, so the first point I wanted to make, so when we're talking about open dialogue, so it's an approach to psychosis that was developed in Finland, and it's considered recovery oriented, and it's a network-based approach, which obviously we'll share more about. But the other important point to make from the start is when we're talking about open dialogue, we're really talking about two related components. One is a system of care that is organized in a way to facilitate continuity and ultimately, hopefully, to facilitate recovery for individuals experiencing psychosis. And the other is, the other way to think about open dialogue is as a therapeutic approach itself, a way to engage a person at the center of a crisis and their support network. Sometimes the latter way of thinking about open dialogue is referred to as dialogic practice, but the terms can be used interchangeably. So a little bit of history. So in the 1980s, the country of Finland had a national schizophrenia project just looking at an increased rate of schizophrenia in the population and wanting to improve the public sector's approach to treatment of schizophrenia. This was led by Professor Alonen and ultimately led to him developing with his colleagues something called the need-adapted treatment model for psychosis. This is really the origin story for what evolved into open dialogue. And need-adapted treatment does several things, but it really puts an emphasis on the role of psychotherapy as a way to help people recover from psychotic experiences. And so the overall intent was to work to reduce chronicity of the illness and to work towards deinstitutionalization in the country. So up here in sort of in northern Finland, the Laplands area, you'll see Tornio, which is where the open dialogue project was first developed. So Jaakko Seikala was the lead psychologist for the team that developed open dialogue. And again, they drew on ideas from Alonen and others to sort of shape the way they approach working with their patients and their families. So they integrated ideas from psychodynamic psychotherapy, from systemic family therapy, and others. They worked on incorporating the client and their network into treatment planning from the start. They developed a practice of holding these network meetings as early as possible in response to a crisis, and ultimately working to have them be held before an admission, as almost a mobile crisis response. And the approach evolved over time. We'll certainly get more into the nuts and bolts of the approach as we continue the conversation this afternoon. And so, there may be this you may be wondering, so there's this project that happened in Finland. How did this sort of reach all areas of the world? How are we talking about this today? And the group in Finland really saw remarkable responses to their treatment approach. So they had a study working with early patients with early psychosis, early non-affective psychosis, and they really reported remarkable rates of improvement. They had 82% of their population did not have any residual psychotic symptoms. 86% had returned to their studies or a full-time job, with only 14% on disability allowance. And they had low rates of relapse and relatively low rates, modest rates of neuroleptic medication use throughout the course of that 5 years of treatment. And a few years ago, they came out with a 19-year outcome study that showed that some of the benefits they were seeing within that 5-year window were sustained, including lower duration of hospital treatment, again, and continued low use of disability allowances and medication use. The sort of rub here is that the clinical team doing the work was also the research team conducting the research, and the research has been pretty highly scrutinized and yet to be replicated. But still, the promise of the approach drew attention first in Europe, and really that attention has spread to really all parts of the world. Rob, I don't know if you want to add any comment here.
Well, I think, in working in a coordinated specialty care team at Grady, just sort of looking at these numbers, it's just really quite remarkable. And as Justin was saying, I mean, I think this really got the attention of a lot of people, especially how many folks were not using antipsychotic medications.
Yeah, and we'll touch a little bit on sort of the philosophy or mindset around medication use as the talk continues, and depending on how curious you all are about that, we can address that in questions at the end as well. So everyone got really excited about this approach, but what is it? And so we talk about both the 7 principles and 12 key elements of the approach. In general, the first really 5 principles address more of the system of care idea around the approach of open dialogue, and the last 2 kind of key in on more of the therapeutic element or therapeutic approach of open dialogue. So the first is pretty clear-cut, immediate, the idea of immediate help. So the team really acted as essentially a crisis service team, where people would reach out from the community. It might be a family member, it might be a person in crisis themselves, it might be a GP or other physician, teacher, school counselor, etc. And they would reach out to the team, and the team would respond as quickly as possible. You even hear about stories of, same day, kind of within hours of being contacted, a first network meeting happening, with the idea of bringing everyone together who is connected to the crisis as soon as possible, ideally within those first 24 hours. The principle of responsibility simply means that the first person who's contacted by the referring person takes on the task of arranging the first meeting. There isn't sort of a downstream referral process. Oh, okay, now I need to call this person, they'll reach out to you in the next day or so, and et cetera, et cetera. It was really seen as we are both responsible and responsive to that first call, and act swiftly to get involved. Flexibility and mobility refer to the idea of the time and place of the first meeting being held, and really subsequent meetings as well, being held in the least pathologizing setting possible, right? So if we're able to meet, if the team was able to meet in someone's home, in another community space, that would be ideal. If it needed to happen in a clinic or in the hospital, then if sort of the circumstances dictated that, that's that's how it would go. But the team was trying to be both flexible and mobile in the way they thought about this. And treatment is adapted to the needs of the individual, and that's where you sort of get that need adapted treatment from Allen and influence here. Adapted to the needs of the individual and the family over time, and they're flexible over time, right? And we'll talk a little bit about the way network meetings work, but it's not just about holding the network meetings. It's about sort of coordinating and collaborating across treatment modalities as appropriate and sort of as driven or as identified by the network themselves. And no part of the treatment plan is assumed on the part of the treatment team, and that includes medication. So and antipsychotic medication or any medication for that from that standpoint. So medication is carefully considered as the treatment unfolds, and not assumed to be part of the treatment plan, that because someone is in the hospital or because someone is coming into the clinic that they're going to agree or medication is going to be a part of their treatment plan. So when it comes to social network perspective, this is a very important part of the approach. So from the start, when a family reaches out in crisis, a discussion occurs regarding who is involved, who could be helpful, and who should attend the meetings. And certainly the person at the center of concern is the person who their opinion about that is at the forefront. And so, but it's communicated from the start that a network-based approach is used, and that's where the emphasis lies. And so that might include, again, it might include or it often would include family members, but might include other members of the community. It might involve a teacher, a primary care physician, et cetera, depending on the circumstances. And treatment decisions are made in the context of these network meetings. It's not like they happen and then the quote unquote real work happens in some other context. It's really the driver of the treatment. Psychological continuity refers to this idea that, the team was really the team across settings. This was something they had the flexibility to do in Tornio. The way Jaco would talk about it is, the team would walk down, the inpatient unit was on the first floor of the building and the outpatient clinic was on the second floor, right? So the team would literally walk, from one floor to the next to continue the work. But this idea about continuity and this emphasis on, the way stories are told and the way stories are understood over time can only or optimally can take place when you have the same team members involved. And we're all familiar with issues around clinician turnover, et cetera. But to the best of the team's ability, you try to keep that continuity there for as long as possible. And ideally, if a crisis resolves and people move on and it arises again, the same team is reformed whenever possible. So again, in terms of more of the therapeutic ideas that guide this approach, sort of two key ideas. So one is the tolerance of uncertainty, this idea of tolerating uncertainty. And I like to think about tolerating uncertainty in two ways. It's the clinicians themselves tolerating the uncertainty, and then how do you help a family or a person in crisis better tolerate uncertainty, the uncertainty that's inherent in these situations. So on the clinician side, it's really an attitude. It's really an idea of how can I have a willingness to be surprised about what might come up in a session, or what might come up in terms of how I'm thinking about the distress someone is presenting with, or the distress a family is going through, and to really avoid premature conclusions or ideas about what might be helpful based on only a little bit of information, or based on only one session, and certainly based on maybe a phone call or reading about someone in a chart, etc. By doing this, you really allow a space to where people can, it's not sort of predetermined kind of how the conversation will go or what it will focus on. And that flexibility and that space is so key to, I think, what makes this approach unique and special. And then you have to, more importantly, help families and the person in crisis or the person at the center of concern tolerate the uncertainty of the situation. So you do that by being available, right? And in Tornio, they would hold meetings frequently, daily if needed. We were able to parallel some of that in our own clinical work, meeting multiple times a week if needed, or weekly. And so, you know, if you give things space and you create that time, it helps avoid things from crystallizing too quickly, because once a certain narrative takes hold, it can be often very difficult to sort of create space for another way of thinking about things.
And, you know, Justin, I would also say that this is really one of the very, very important elements of open dialogue, that for especially like I've worked in residency education for a long time, and like one of the goals of residency education is you actually help to cultivate people feeling kind of comfortable and kind of cultivating an expertise. And this idea really I think gives people permission to kind of take a step back and wonder, are there other possibilities? You don't have to come in and always have the solution. The solution is generated, as we talked about, from the network itself.
Absolutely. So the topic of dialogue is kind of a big one, but we'll try to give just a few ideas to help give folks a sense of what it means. So dialogue really comes down to a process of trying to understand, how do you help someone, especially someone whose voice may have been marginalized because it's been being misunderstood or not understandable. How do you help that, give that person a sense of agency and uphold their voice when it's difficult for them to do so on their own? By doing so, and in the process of creating dialogue, really what you're hoping to accomplish is developing a new understanding of the crisis, of someone's experience that is formed in the language of the network. So this is key. This is another aspect of tolerating uncertainty too. They're certainly interconnected. This idea of, I think oftentimes we have the experience of people come to us with their experiences, their distress, their symptoms, if you want to use that language, but they use their own words, and we often translate those words into symptom-based language or psychiatric language. And just being mindful of what's lost in that translation, and maybe some things are gained too, and being curious about that is okay as well. But it's being very curious about the specific words that are being used and the way that they're being used in the family, in the network, and by the person at the center of concern. And I'll give an example about this in a moment that will hopefully shed some further light on this. Dialogue is a little bit of it's easier to show than tell when talking about this. So we'll try to do that here in a few minutes. And one thing we're aiming to do in these network meetings is creating a space for things that have not yet been spoken. And there can be multiple reasons for why something is yet to be said. It could be that there just has not been a space that's been created for the person to share that idea. Or it may be that, you know, they weren't able to come to that idea on their own, and that the support of the network helps them find the words to share this idea that is inside of them in some way, and maybe causing them some distress, or it might just be important for the network to hear. The other aspect of dialogue that is really important is this idea of polyphony, or multiple viewpoints. So when we talk about polyphony, also I have sort of two ways of thinking about this. It's really an approach or a way to think about all voices as being equal in the network, and not avoiding the hierarchy that typically exists within the context of psychiatric care. So we think about outer polyphony or horizontal polyphony. So if we're in a network meeting and we're sitting in a group, that everyone in the network has an important voice, and that we try to hear from each voice, and give space for each voice to share if they are interested in doing so. And then, so that's outer polyphony. And then the other idea is inner polyphony or vertical polyphony. So this idea that we all have different voices that we speak in. So there are times when I'm speaking as a psychiatrist, as an educator, as a father, as a son, as a brother, and that I have these voices inside of me, and those are, different perspectives at times that to bring out, and that they each have value. And depending on the context, one voice might be particularly of use or of value to the group. I think this can be very empowering, because oftentimes people who are experiencing psychosis, I think, receive the inherent message that they're not supposed to talk about their voices. And this, in contrast, is saying we're very curious about the different voices or viewpoints that you hold, and finding ways to bring that out in the conversation is really an important part of this process. Another way, and sort of the intersection, I would say, at least the way that I think about this, between outer and inner polyphony is bringing in outside voices to the conversation. So, for example, if I'm meeting with a family and someone, maybe the grandmother who is being spoken about is missing from the meeting, she's not in the meeting for whatever reason, you might ask the network or a member of the network, what do you think do you think your grandmother might have some words of advice for you, or some thoughts on the conversation that we're having? This is a way to bring in another voice, but of course the person is giving their perspective on what that other family member might share. But it's a nice way to especially if the group is stuck, or it seems like there's a really important voice that's missing in the conversation, that's a way to bring that voice in. Bring an aspect of that voice in is maybe a better way to put that. So that's a bit about the principles. There's a little bit of overlap between the elements and the principles, and we're not gonna go through these one by one today. But a couple things that I wanted to point out. One is that in a network meeting, we obviously talk about the network being the person at the center of concern and their support network, but it also includes 2 or more clinicians or facilitators in the meeting. And this is important for many reasons. One of the key parts of the importance to this is the role of reflecting, and we'll talk a little bit about what reflections are in the context of network meetings in a moment. And so, but yeah, so why don't we go ahead and move forward? Rob, I don't know, I just want to create some space if you want to share anything that's on your mind at the moment.
Well, I think the 2 or more facilitators is really important, and that can be sometimes, and we'll talk about the practicalities of this, but in fee-for-service settings, it can be really hard to bring in the second facilitator, which is where grant funding really helped us. And there's also other models in which you can have 2 people working together in some of the team-based approaches, like in ACT and coordinated specialty care. Yeah. Okay.
Yeah. Awesome. So this paper, just want to put this out there. This is an important reference if you want to learn more about it reviews both the principles of the approach and the key elements by Mary Olson, Jaakko Seikkila, and Doug Zidonis. This is kind of like one of the first places I direct people if they're interested in learning more, specifically around like sort of the nuts and bolts of the approach. So just a couple comments about network meetings themselves. So we've said there that the context for dialogic practice, really an emphasis on withness rather than aboutness. And clinicians involved are encouraged to drop or lightly hold their clinical gaze, right, into the room and be present as people. Bring in your clinical expertise when it seems appropriate, or when it's invited in, but don't necessarily lead with that clinical expertise. There are two key questions that we start the first meeting with, and then the second question is used as the opening question for any subsequent network meetings that occur. So the first is, what is the history of the idea to have the meeting? And this question was taken from Tom Anderson. And the idea of this question is to get a sense of how much those who are present in the meeting are committed to the idea of being present. And it's really a nice way to get a sense of, where each person in the network is at in terms of this conversation that's about to take place, and a bit about the history that led to the meeting occurring. This in the first meeting, the next line of questions you go into, and again, we sort of start subsequent meetings with this question, is how would you like to use our time together today? And this idea is about empowering the network and co-creating an agenda. So when I'm working with, and I actually use this question when I meet with all the people that I work with, even if I'm working with them one-on-one, it's an opportunity to co-collaborate on an agenda, as opposed to me assuming that, we're going to talk about X, Y, or Z, or that the things that I think we should talk about are the most important, et cetera. And in the context of a network meeting, each member of the network is asked this question as a way of, again, sort of emphasizing the importance of polyphony and addressing any hierarchy that occurs in the treatment and in the family.
Real quick, Justin, I'm wondering, is there any ways you've ever rephrased this first question a little bit in your work? I've seen some permutations of it that you've done before, and I just wanted to see if you wanted to share some of those, slight modifications to the wording.
Yeah, I mean, so yes, I mean, to be honest, this question, it can be a little awkward. Just the phrasing of it. What is the history of the idea to have the meeting? I sometimes do ask that exact question, but oftentimes, I was the one who prompted the meeting, right? And it's a little, I don't want to say silly, but it might be a little odd for me to be the one. Well, what's the history of the idea of the meeting? And everyone looks at me and says, "Well, you asked us if you wanted to have a meeting." So what I've really become accustomed to doing is asking folks about when they first learned about the meeting and what were their initial thoughts about meeting in this way, and just getting a general sense of, did they find out 5 minutes before they were supposed to leave, or 5 minutes before they hopped on the Zoom, or did they talk about it, over the weekend with their mom or dad or son or daughter, and they were all in, or they were really excited, or they were dreading it. And another thing that I try to do with this question is really connect with the person who seems the least interested, or maybe, and you're making some assumptions in this, but sort of the person who seems like the most distant in the room, and really making sure, depending on the circumstances, that I connect with that person early to, communicate that I really value their being there. And I'm very curious to hear about, their thoughts about having the meeting, and how they would, what they think would be a good way for us to use our time together today. Or if they were to leave this meeting feeling like we had a good conversation, what might happen is another way of thinking about that second question as well. There's sort of from, a lot often, and you can almost spend sometimes an entire session on those first two questions. A lot often arises, especially early on in this work. But there are really two kind of primary dialogic skills that we use sort of to facilitate the meeting from that point on. Responding and reflecting. Responding, to be honest, is a little bit of psychotherapy 101. I just want to put that out there. But it's really about being attentive to the use of language in the family, using the words. I will often repeat the exact words with the exact phrasing of a member of the network, that if it particularly resonates with me, or it's a way of, it's kind of a way of inviting someone to go deeper into their thoughts, by simply just mirroring back the words that they're using. And also this includes responding to certainly paying a close attention to and potentially responding to nonverbal forms of communication, paying attention to silences, using silence as a way of creating space for someone to go deeper into the thoughts that they're sharing. The other skill, and again, this is something that we could spend a lot of time on, is this idea of reflecting. And if you had to ask me kind of what's the special sauce with this approach, I don't know, Rob, if you would feel differently, but I think the reflecting process is probably it. So I like to think about reflecting as a conversation within a conversation. So what happens in a reflection is periodically during a meeting. So let's say in a 1 hour meeting, you might have 2 reflections, 1 to 3 reflections, depending on the circumstances. And a reflecting conversation occurs between the clinicians in the meeting. And so we turn to each other almost as if the family was not in the room. But of course, when you're in the presence of the people you're speaking about, you're more inclined to use respectful, person-centered language. But the clinicians turn to one another and simply have a moment sharing what's coming up for them in the meeting. What is standing out to them about the conversation? Did any images come to mind as someone was sharing? Are there any questions that are, coming to mind for them? And it's really it's sort of it's an approach to like radical transparency, where I think in getting feedback from folks that we work with, they say, I've never had clinicians sort of say what they're thinking in the moment in front of me. And it's a little bit of this idea of, we have these conversations sort of behind closed doors, or, even explicitly, like, or you leave the room to staff a case or something like that. But these conversations are happening in the presence of the family. And then families are invited to respond. So, what did you think of the things that were shared? What stood out to you about that? Was there anything that we got particularly right? Was there anything that we got particularly wrong? And again, these are all ways of facilitating more dialogue within a group.
Yeah.
Go ahead, Rob. Sorry.
I really agree with the sort of thinking about the reflecting process as the special sauce. I think when I am doing my best reflective work, it's sort of, I'm thinking to myself, what would I say right after we finish this meeting to my colleagues after we're finished with the meeting? And then incorporating that actually into the conversation. And it has this very interesting effect of actually then changing what you say outside the meetings. And there's less gap, I think, between what you say inside the meetings and that's outside the meetings. And overall, I think it has just led to using much more, sort of respectful and thoughtful language, like in the reflecting process and then outside of it.
I think in the interest of time, Rob, we might have to skip my storytelling here. I don't know if you have any.
Okay, well, maybe we can come back to it.
Yeah, sounds good.
Yeah. So now after you've gotten some of the background for open dialogue, we're going to tell you a little bit about some of the work that we've done at Grady. And we called the project Open Dialogue Atlanta, understanding that open dialogue for us is sort of aspirational, and we really wanted to include many of the key elements of open dialogue. We weren't going to be doing open dialogue exactly as they've been doing it in Tornio. We understand that this work sort of by itself is need adaptive treatment, and there are going to be certain adaptations that needed to be made. We ultimately decided to call it Open Dialogue Atlanta, and we'll tell you a little bit about that. All right, next slide. This is our hospital. This is Grady Memorial Hospital, part of Grady Health System. We're a safety net hospital in Atlanta. We work with a large number of individuals without insurance or folks who don't have adequate coverage for their needs. We have a large mental health sort of section of Grady. We have inpatient, outpatient, emergency services. You can see the outpatient volume per year is over 6,000 unique clients, 80% identify as African American, and in our outpatient data, about 30% have some sort of psychosis condition as their primary diagnosis. We also have a number of subspecialty clinics within the outpatient behavioral health clinic at Grady, which we heard a little bit about already. The P-STAR program, we have 3 assertive community treatment teams that Justin runs, and we have a first episode program, a med psych clinic, so that's a little bit about our services. All right, next slide. So now let's talk a little bit about how Open Dialogue came about at Grady. And there were a couple things that were going on at the time. This was sort of, it was all getting off the ground in 2015, 2016. And at that time, I was working on the inpatient unit. I was the medical director of the inpatient unit. And I was also part of this outpatient program. And I was able to see some similar folks going from the inpatient unit to outpatient. But there was just a noticeable lack of continuity in the services. It kind of felt like families were somehow being excluded from the treatment process in many areas, and that was a bit unsettling. And we had also been a site for the RAISE study, which was a study looking at a coordinated specialty care model for people with early psychosis. And we were a control site, and actually we were seeing a really high number of early psychosis folks on the inpatient unit, between 5 to 9 per month. And we desperately needed specialized services for folks with early psychosis. So kind of, we were so fortunate that a foundation called the Foundation for Excellence in Mental Health Care, now known as Open Excellence, reached out to us and said, hey, we're interested in doing this thing called Open Dialogue. Would you be interested in doing it at Grady? And I said, they approached Keith Wood and I, and we were kind of like, well, tell us about what Open Dialogue is. So we heard about it, and it really resonated with a lot of the things that, with our core values, and I think with some of the gaps in our services and kind of the way that we wanted to ultimately organize our services. It was very much aligned. Okay, so next slide. So we knew that although there are things about Open Dialogue that sound just sort of like routine, good mental health care, it's quite different in many ways in how it's organized and set up. And it's kind of radical in some ways. So we had an organizational change model called AppTalk, which was brought on board from some colleagues at UC San Diego and University of Massachusetts at the time. And they had done work in organizational change from tobacco and how to kind of reduce tobacco use among folks with mental illness. And they adapted, so we were able to adapt this model to Open Dialogue. Our training, we had 3 initial visits from a training team that included Mary Olson, who was an international leader in Open Dialogue training, Doug Zadonis, and Eileen Small. We kind of formed a small team together when we'll talk a little bit more about the composition. It was important for us to evaluate this because it hadn't really been done very much in the US. We were really, I think, motivated by Chris Gordon and his colleagues at Advocates, who had really implemented the first Open Dialogue study in the US, first implementation project. And we wanted to look at this work in a very, very different context. So our idea was that we were going to do this clinically, and there would be a research component. Not everybody that we worked with was actually going to be in the research component. And we received funding from 3 philanthropic groups that you can see there. This is a little bit more about the organizational change model called AppTalk, which we're not going to get too much into right now, I think just because of time's sake, but it's 3 phases. The first phase involved an organizational scan where people from outside kind of came in to our outpatient clinic at Grady and said, oh, this is sort of interesting. What do you think about this? And could any changes be made? It was a thoughtful implementation that sort of affected policies and procedures, I think, right out of the get-go, and also had got the leadership buy-in very early on from leaders at Grady and also leaders at Emory. Okay, next slide. So the team that we had was, it was a wonderful team. We had a number of different people. We had 5 psychiatrists, 5 counselors, 5 LPCs, 2 psychologists, 2 research staff. And this distribution was actually, there were more psychiatrists in our program than we had seen in some of the other programs. And I was always curious how that was going to affect things about like medication and the philosophy around that. We had a lot of trainees, which I think was one of the best parts of this. And Justin, when he began his journey with Open Dialogue, was a trainee and really one of our, really was just instrumental in making this work. Justin, do you want to say anything about what it was like at that time?
Yeah, I mean, it was very exciting. I feel very privileged that I was introduced to this approach very early on in my career in psychiatry. It was my second semester of residency. We don't really talk about it in that way, but second half of my first year of training, when Rob came to me and saw my interest in working with families, and yeah, so it was a wonderful group. And really, I think that, in a slide here in a moment, talking about successes and challenges, one thing that we don't mention in that slide is this idea of, it really was a true collaborative effort, multidisciplinary collaborative effort that I think, you do not see very often in sort of general outpatient behavioral health clinics, right? Where sort of everyone's, off doing their tasks and sort of you cross each other in the hallway. So really just a fantastic way of collaborating with others and feeling a lot of support in that process as well, doing this very challenging work.
And an Open Dialogue is so wonderful, I think, to get involved with as a trainee, because I mean, I remember I had been, an attending for 6 or 7 years or so, and I would have these sort of like periods where there would be these tectonic plates shifting in kind of how I thought about the world and how I thought about psychiatry. And I feel like I actually unlearned a lot of things that weren't helpful to kind of keep with me. And, maybe that's true. That maybe happens for trainees too, but I had been at it for a longer time, and maybe the unlearning process took longer, and I'm maybe even still working on it now. This is just a little bit about some of the clinical services for that we had in our Open Dialogue program. Primarily, we did outpatient clinic-based meetings. We didn't exactly have the bandwidth to go into the community as often as we would have liked to. We did try to respond quickly with someone came to the program within 24 hours or when they were in a crisis. And then we also functioned kind of as a system within a system at Grady. So there was this other sort of broader process that was happening, and we sort of had this. We were kind of sequestered off in our Open Dialogue work. We met with many of the individuals on the inpatient unit initially. Some of the same team members saw them on the inpatient unit, and then were able to provide some psychological continuity. And yeah, okay, let's go to the next slide. So here's a little bit about the study that we ultimately published this year. We did a 12-month feasibility study. And individuals that participated were relatively young, 18 to 35. They had some sort of experience of psychosis. There was one supportive person who was willing to participate. And we looked at 5 different feasibility domains. Okay, next. This is a little bit about the implementation timeline. And I think this is important because like Open Dialogue came out of nowhere really in 2015, late part of 2015. We got this team up and running in 2016. We began doing some network meetings at the end of 2017. And we wanted to get a little bit of practice and familiarity doing these. And then we started doing network meetings in the study about 6 months after we began network meetings overall. So it was sort of relatively rapid project to begin the evaluation piece. One of the biggest contributions, I think, in addition to his clinical work that Justin had made, was the development of this fidelity checklist, which maybe I can have you say some things about.
Yeah, and I didn't include the slide where we actually show the checklist, but happy to share it if folks are interested. But basically, it was a way to debrief after meetings with, not about the content of the meeting, but really about the process. So as we were learning this approach, like, how do we know if we're doing a good job, or how do we know that we're sort of adhering well to the approach? And so we use this check. It was a sort of a quick way to kind of debrief about the process, like less than 5 minutes, and I think was a really helpful way to kind of check in about how we were doing and refining our approach over time.
All right, we also did some limited efficacy measures and used some traditional mental health scales like the BPRS, or like some measures of functioning. And largely these were similar ones that were done in advocates, and many of the same scales were modeled. And we found, in a limited way, efficacy wasn't really the point of what we were doing, but we found that people's mental health symptoms did tend to improve over a 12-month period, and there were some improvements in functioning. Now, to measure acceptability, we had some qualitative interviews that we had done with our participants with some really, really rich data. Some of the quotes that stood out included, I have some diagnosis, things weren't going my way, I'm in between emotions right now. One of the participants mentioned that they felt like the clinicians were really paying attention. The professionals were really paying attention. And I think like the experience of doing the work in open dialogue, I know required me to really focus on how can I be really present during these meetings, because I think whatever I was doing before, I wasn't present enough. And it was a big shift to become really, really present in these meetings. So the qualitative interviews that we got ultimately showed that that this model was acceptable for the participants that we worked with.
Yeah, I just want to add one. This last piece was also just resonated a lot with me, that participants really experienced this process as a new sort of resource in their life, where they would talk about outside of the context of treatment. That if things were if there was a tough conversation at home, they would have quote sidebars with their family, or quote do an open dialogue. So this was really kind of a new resource for folks to use, again, even outside of the formal treatment. This is the citation for those who want to read more about the study. And I think not to pat ourselves too much on the back here, Rob, but we were, over the course of this project, we were able to work with over 100 networks. We were able to, we felt that the approach was feasible with relatively brief training. So formal training is 2+ years normally. And like Rob said, we really kind of whittled that down to starting in sort of a few months, which was amazing. And we're really able to incorporate this into an outpatient clinic that, where there was a huge need, and really experience a shift towards, I think, a more humanistic, person-centered, and, as I said earlier, collaborative way of working with each other. Sorry, I didn't. Go ahead.
I'll never know. Like, I feel like there's folks that we initially met in the open dialogue sort of model that otherwise I don't think we would have connected with. And many of these people we're still working with now.
Absolutely. It wasn't all roses. There were certainly some challenges. So like is often faced in community mental health clinics, staff turnover. Rob mentioned the idea of only pretty much being able to meet only in clinic. And there was also the sense of, Rob referred to us as a system within a system, that it was hard. It was sort of, because we were functioning sort of as our own team, it was sometimes challenging to work with other treatments outside of that open dialogue context. But that's something that we are kind of working on in phase 2 and 3 of our open dialogue work at Grady, which includes Rob's work in Project Arrow, where they've sort of combined coordinated specialty care with open dialogue. And I'm doing slightly less formal, but also incorporating this work into our ACT program. We've done our own trainings at Grady in the approach, and looking at other ways to incorporate this way of working into the things we do. So
I'll just say one other thing real quick. I think that the transition to in-house trainings is a really significant one, because open dialogue, getting the training can be quite expensive, and it's also quite and it can be pretty extensive. So Justin became, as we heard, he's an internationally certified trainer. We have another trainer in our system as well, Sylvia Browning. And last year we had our in-house trainers actually give Project Arrow a training, which I thought was, so shifting to in-house training, I think, is a really, really big issue in terms of sustainability.
So we intended to give 10 minutes for questions, and we have 3, but welcome any questions that folks have. A little bit of a whirlwind review.
Justin, I wonder if maybe we could, maybe we could address Dr. Davidson's question in the chat. So he'd love to hear more about the narratives that can crystallize harmfully, and how an open dialogue team might work with a network to identify and shape a more helpful narrative, perhaps, and if we have any examples around that.
Yeah, Charlie, I appreciate the question, and I know, I think that first thing is that sometimes ideas crystallize, they may be harmful, they may not be, right? And being curious about the way that certain language has been used around someone's experiences can be, and just exploring that within a family can be extremely helpful. I can kind of give a short version of the story I was going to tell earlier. So I was working with a network. Actually, they were working with our team, and I was filling in for a colleague one day, and I was meeting with this family for the first time. And the person at the center of concern was a young man, and he was there with his parents, a college-aged man, and his parents, and his younger brother. And the identified patient had been in a school program, and he was talking about this pressure he feels to really be accomplished and do really well. And his father kind of, that resonated with his father, and said, I have had similar experiences, and I always feel like when I'm being tested on something, I need to do really well. And I commented on, wow, it seems like, you understand a bit about what your son is going through with this. And the father says, well, yeah, except I've never had an episode. And as he said the word episode, he literally waved his hand away from him, like he was trying to throw that word away from him as far as possible. And suddenly this moment of sort of connection and warmth was broken up by this feeling of separation. And I thought about addressing it, kind of that experience in the moment, but decided to wait for a reflection. And in my reflection, I shared with my colleague, I wonder if the patient's father has gone through any experiences that help him better understand what his son was going through when he referred to, an episode. Just kind of put that out there, just being curious. And we kind of turn away from our reflection, and I say, well, does, any thoughts about what we just shared? And the patient's mother stands up. I think she literally stood up, and she pointed to her father. Maybe she was still sitting. She points to her husband, and she goes, he's had an episode. And I was very caught off guard by this, but then she went on to, her and her husband went on to explain how after his mother had passed away, he got really depressed and really struggled for quite some time to kind of, get things back on track. and it ended up being a really beautiful moment. And then they start talking about this idea of an episode, and they start to laugh about it. And then the younger brother says, "Well, what was my episode?" And all of a sudden this a joke is made, and all of a sudden this word episode that was a source of sort of pain and separation transformed in just a few minutes into something that the family is sort of connecting about and kind of lighthearted about. And anyway, just a small example, but I think an important example of sort of the way language can evolve even quickly in the context of these meetings. So any other thoughts as we work towards wrapping up?
I think that's going to be all that we have time for today. Thanks, Dr. Cotes, and thank you, Dr. Clancy, for such a great presentation. Everyone, please take a minute to fill out our SAMHSA required surveys that I've posted the link for in the chat. And we're just a little bit over time, so that's going to be all that we have time for today. Thanks, everyone.
Thank you.
Thank you.